Good morning, everyone in Schema Therapy Made Simple. I'm very excited today to have the wonderful Dr. Patricia Rotman all the way from Argentina with us in Schema Therapy Made Simple. Welcome. And before we begin, I'd just like to acknowledge the Noongar people of the Whadjuk lands and the lands that I'm presenting from this morning. Welcome, Patricia. It's so lovely to have you here.
Lovely to be here. Thank you, Nadine, very much for your invitation.
Yes, I've really been looking forward to it because we both love trauma. But this is special because we're talking about acute trauma, which is something that I'm not working with very much. So even just in our few meetings discussing it, I thought, wow, this is going to be really great and I'm going to learn a lot too. So thanks for being with us. So for those of you who don't know Patricia, she is a clinical psychologist and she's been in practice for more than 25 years, both in the United States, mostly New York City, and Argentina. She has a PhD in health and human services, and she has a New York license in social work as well. So Dr. Rotman is an assistant clinical professor in the Department of Psychiatry at Mount Sinai School of Medicine in New York. She co-founded the ISST Trauma Special Interest Group and has been coordinating this group since 2016. And I was lucky enough to participate in that recently, and it's a wonderful group for anyone who's interested in that. And Patricia just brings a wealth of experience to it, which is lovely. Patricia has trained in a number of therapeutic approaches, but has more of a specialization in CBT and schema therapy. She's made several presentations at ISST conferences and some international webinars in the area of trauma and schema therapy. And so after living in the US for 23 years, Dr. Rotman moved back to Argentina in 2015, where she developed a schema therapy training in Buenos Aires. And her interest areas are acute trauma, complex trauma, migration, multicultural issues, and integrating different therapeutic approaches with schema therapy model. And one thing that I think is amazing about Patricia is that she can do therapy in about 4 or 5 languages, which is such a gift, and not many of us can say that. So is there anything else that you'd like to tell us about yourself that I missed?
That was a very thorough, very nice introduction. Thank you. Thank you very much.
Thank you. Yeah. Okay. Yeah. So tell us a bit about how you became a schema therapist.
Okay. Well, I am originally from Argentina, from Buenos Aires, and the dominant model was psychoanalysis. So for several years, I was a psychoanalyst. Mm-hmm. So I think that psychoanalysis is a fascinating theory, and patients are able to understand themselves quite well. But I realized quite soon that there was very little change. So many years of therapy and little change. So I decided to train in CBT and love to see how effective different protocols are. And I was very excited to realize how fast patients would overcome their symptoms. But as you all know, CBT is oftentimes not enough. So I met Dr. Jeffrey Young at Cornell University around 2004. And I fell in love with schema therapy immediately. And soon after, I began my training in New York City. So, of course, I especially enjoyed how integrative the model is and the thorough case conceptualization. Mm. And many of my patients who could not benefit from other models began to improve with schema therapy. So I had the privilege to belong to our peer supervision group in Dr. Jeffrey Young's Institute and to share cases and ideas. We had Janet Klosko, Jeff Conway, Travis Atkinson, Marsha Blank, Scott Kellogg, among others. So I have been basically using schema therapy for almost 20 years and continue realizing how effective it is. And living in New York City offered me the chance to train with the creators of other models, such as Marsha Linehan, Sue Johnson, Dennis Sturge, And I always love the idea of integrating their contributions to schema therapy, but always basing these interventions, these strategies on our clear and thorough case conceptualization. So here I am.
Wow. I didn't know that you started as a psychoanalyst. That's really interesting, because I'm sure there's some things you can draw through to your schema therapy practice, but it's quite different. So thank you for sharing that with us. Can you explain to our audience what acute trauma is and how a client may present when in an acutely traumatized state?
Sure, I'll give it a try. So acute trauma refers to recent trauma. It's a trauma that occurred days or a few weeks before. And the traumatic situation is related to direct or indirect exposure to death, severe injury, actually threat of death as well, and or sexual violence. So acute trauma may present with severe stressors that are potentially traumatic as well. And there are different terms associated to acute trauma: acute stress disorder and acute stress reactions. Acute stress disorder is a diagnosis that we will see in the DSM-5 and the DSM-5-TR. So it's a controversial diagnosis, and some experts believe that it does not exist because they believe that these are normal reactions to an abnormal event, and most individuals will get better without professional help. And I do agree with this, but there are some patients who need our help, individuals who need our help. So I believe that identifying frequent symptoms will be helpful to clinicians. So some of these symptoms include intrusive thoughts and images. For instance, a woman was a witness of her father-in-law shooting himself. For several weeks, she could still have recurrent thoughts, recurrent visual images, and hear the gunshot. Individuals may also have dissociative symptoms such as depersonalization or derealization. For instance, immediately after September 11, I was coordinating an anxiety disorder group, and one of my patients said, "My voice seems to be coming from outside," and also said something like, "I do not feel my hand is my hand." He was looking at his hand, feeling confused. So some other symptoms are avoidance of trauma-related situations and thoughts, hyperarousal, having difficulty sleeping, startled responses with sudden noises, among others.
Okay. Yeah, so it's interesting because I agree with you that when people are that distressed, so they've witnessed something or they've been assaulted or attacked, often their functioning is so impaired, and to allow them to continue without any psychological support in that state seems quite cruel to me. So, being able to provide something that will help move them towards a healthier adjustment or just a more tolerable day-to-day existence, I think is quite important. So thank you for that definition. How do you find acute trauma different to PTSD and complex trauma?
Okay, that's a great question. Acute trauma and PTSD have similar symptoms, but the difference is the onset and the duration of the disorders. Acute trauma for the DSM-5 and TR begins 3 days after the traumatic situation and ends after 30 days. Later on, the person may or may not meet criteria for PTSD. Approximately 50% of individuals will not present PTSD. And this depends, of course, on the presence of protective and risk factors. Complex trauma is more associated to ongoing traumatic events. So it could be related to ongoing childhood abuse or neglect or current traumatic situations as the devastating war in Ukraine or the earthquake in Turkey. So complex trauma is more likely to exacerbate or create more severe psychological consequences. And schema therapy, of course, as you know, Nadene, has shown to be very effective to help patients with this disorder. Acute trauma with ongoing exposure to severe or traumatic stressors is more likely to lead to PTSD. And unfortunately, of course, it's more likely to lead to its comorbidities, such as substance abuse and major depressive disorders.
Mm-hmm.
So one key difference between acute stress with ongoing traumatic stressors and PTSD is that memories remain in an excitatory state, and these ongoing stressors prevent the memory from consolidation in a hopefully adaptive way. So traumatic memories may remain fragmented among people who have acute trauma, and therefore there's no generalization effect when doing reprocessing. So I think this is an important difference.
Okay, that's great. So schema therapy is usually used for long-standing difficulties. Can you share with us about how you came to use schema therapy for acute trauma?
Sure. Well, there were different pathways that led me to realize that it is an effective intervention to help this population. One is based on my clinical practice. Clinical practice with my new patients, but existing patients as well. So I realized that limited reparenting using image scripting, mode dialogues using chair work, addressing maladaptive coping modes, and strengthening the healthy adult mode were helpful strategies. So I spoke with other schema therapists, and they also shared similar experiences. So I also realized that my schema therapy clinical experience of identifying patients' emotional needs usually led me to quickly identify the core need of somebody who had recently went through a traumatic situation. And my schema therapy experience also helped me to change a case conceptualization with existing patients. That was important. For instance, a patient who had always needed emotional validation when going through an acute traumatic situation with severe ongoing stressors, she was more in need of practical help and guidance. For instance, a female patient whose parents had an almost fatal accident expressed the need of coaching about how to talk with her parents' surgeon. She was very, very anxious about that and felt she could not do it. Or a patient who was usually in detached protector mode needed to be helped to vent and appropriately channel her angry child mode. Now, from a theoretical viewpoint, one of the main assumptions of schema therapy is that individuals have emotional needs. We say that needs are valid, are universal, and people who have personality disorders, of course, have unmet needs. People who present with acute trauma also have needs that are met during the trauma or during the weeks or months after the trauma. Therefore, we know that some of the main needs are safety, stabilization, practical help, emotional validation, hope, and feeling competent. I strongly believe that we schema therapists have tools to help these individuals to meet their needs.
So that's really interesting that it's that idea of the core emotional needs that made a lot of sense to you here, and then that gives you the framework for how to meet people with acute trauma. I love that, because the core emotional needs are my favorite part of the schema therapy model. And now it's making sense to me. Now I'm like, I can see, because I did wonder, and I said to you, how are you doing this? Because it seemed not that obvious to me. So just to consolidate for the listeners, some of the things that Patricia's been sharing, there are tools within schema therapy that allow us to quickly identify what the client needs. And I think that's the beautiful thing about the model all the time, and it makes you able to tailor treatments to clients instead of just providing a manualized step-by-step approach. And also there are tools within schema therapy to help with the memory fragmentation that happen as well. But that's fantastic. So my next question I'm really excited about because it links to this. How do you adapt schema therapy for clients presenting with acute trauma?
Okay, well, the other thing I wanted to mention before, if I may, is that there are two treatments, okay? There are two treatments that have a lot of research backup, okay?
Mm-hmm.
And it's important for us to keep that in mind. And one is, of course, trauma-focused CBT and EMDR. Okay, you're a specialist in EMDR, so I wanted to make reference to this. They both show that early interventions to process recent traumatic memories may help. And they may help to either prevent PTSD or at least to reduce the severity of symptoms, of PTSD symptoms if they occur. So one of the things is why schema therapy? Why think about using schema therapy and not go directly to these models? And again, I think that all what we know about schema therapy makes it like a perfect or a good enough model, at least to help these patients. And CBT, I used CBT for a long time. And CBT was very good. I'm talking, of course, about trauma-oriented CBT, was very good for the patients who stayed in therapy, but there was a large dropout rate, actually. So, and it was very uncomfortable for therapists to use it. So, EMDR has, of course, a lot of backup research, but I was lucky in a way. This was a blessing in disguise to not be trained, not to be so trained in EMDR and to have basic training. And why am I saying this? Because I then used schema therapy, and I realized that schema therapy was very effective and I did not feel the need for another model. Yet I'm very open to integrating EMDR, and I'm trained in the assist model. And I think that's a great model for desensitization, right? But I prefer to use schema therapy, especially image rescripting and modalities using chair work for reprocessing. So I don't know if that's clear. If you have another question
that
about
makes
that,
sense to me. So
we can move to the adaptations if you wish.
Yeah. That's fine.
Okay.
So in terms of would be helpful to know when you respond to that about imagery rescripting and how you might adapt that differently to what we would be doing for a historical trauma or an attachment trauma. Right.
Well, image rescripting has been shown to be very effective for PTSD. And I believe it can be also effective for acute trauma. And it can be effective, but we need to do some changes. Actually, we need to do several adaptations, and we will not have time to talk about all the adaptations of the traditional schema therapy model. But image rescripting is safe, but we should stay away from regression. Regression meaning childhood scenes, okay? Because after all, what we are addressing and processing and desensitizing first is going to be the current trauma, right? Not even past traumas. I think we need to focus on the current trauma. But because of the fragmentation of the different parts of the acute trauma memory, I think it's important to address in image rescripting the different parts, the most disturbing part, the different parts. I mean, we could begin with the most disturbing part. And in this way, I believe that it's very similar to EMDR, right? Because EMDR, the assist model, is going to address different parts and even think about future anticipated problems or disturbing parts of the trauma. So I think that could be one of the differences. The other thing that I like is to co-create the script with the patient before doing the actually imagery rescripting. And this is because the possibility of affect dysregulation is, of course, much more intense than with PTSD. And therefore, co-creating the script, and this is based on, I got inspired with Ehlers and Clark work, with imagery rescripting. I think it's much safer, right? Now, if we have the window of tolerance as our guiding map, and we quickly rescript, when the patient has an amygdalinic activation and this affect activation, I think that the possibility of dissociation, the possibility of affect dysregulation is very small. And I know that some of our colleagues, they argue that we should not be doing reprocessing, that we should just be helping the patient to meet the needs of safety and stabilization. But I do believe that imagery rescripting is very, very safe if done by, if administered by therapists who are very trained, of course. Okay, so I think that's important to mention. Yeah. Yeah, and then other adaptations is, I believe that strengthening the healthy adult mode is very important. And actually, this is also related to imagery rescripting, because one of the things that I like to do, and I showed this very recently in a symposium, in Turkey, is to activate the healthy adult mode modeled after the therapist and have that healthy adult mode, the patient's healthy adult mode, reparent the vulnerable child mode, and also confront the critical voices, the critics that we know very well in schema therapy. So I think that that's we should do like a little bit of a condensed, abbreviated session, when we work with messages coming from the critics and activate, as I said, the healthy adult mode. So concerning that, working with the critics, that's very important, when working with acutely traumatized population, especially guilt instigating messages. I think that's very important because, again, I don't think that desensitization is enough. If the person has critics that instill guilt, or very punitive, that could put them in jeopardy as well. So I think that that's very important to identify fast. That's why I believe that it's advisable that only schema therapists who are very trained work with these cases, because they are very difficult, and there's a lot of course, emotions. So they also have to have, we should have a sturdy healthy adult mode. So not easy work, as you well know, Nadine. And the other thing I would like to mention is that working with maladaptive coping modes is important. This is what we call the defense mechanisms in psychodynamic theories. And I believe they should be respected because they could be adaptive, and they should be honored, respected. They are there for a reason. And so I think that's very important. And if they are really maladaptive and they can put the patient at risk, I think that, well, then we should intervene, of course. I mean, I have so many examples, unfortunately, taken from the Ukraine war and based on supervised patients, that are going through, of course, a lot.
Yes, yeah. Okay, so that's interesting. So the chair work you're using for critic modes and for building healthy adult mode. And this is a little off the script, bear with me. So do you find that sometimes these critic modes are woken up by the acute trauma? So they've been sort of not too bad for the client, and then the acute trauma happens and the critic becomes very loud, or is it just the same?
Yeah, that's a good point. That's a good question. Because, they can be latent other times, but acute trauma activates everything, exacerbates things that were latent. I hope that's the right word in English. Yeah. And so acute trauma can activate schemas, can activate guilt instigating critics, punitive critics, shaming critics. So yeah, I think that we should keep a good eye and be ready to help the patient to confront these critics, and of course to comfort and validate the emotions of their vulnerable side. I prefer, by the way, to call the vulnerable child mode, not little you, little John, little Mary, but the patient's or the individual's emotional side. I think if not, it tends to lead to some regression. So we want to help this healthy adult mode to be as strong as possible. So just mentioning, emotional side would be, I think, better.
I think that's so important, actually. And I wish I'd thought of it myself, but we want to actually keep people integrated with their abilities to feel strong, competent, capable. And if we were to do some of the things that we might do with complex trauma and activate a sense of connection to that child mode in a way that makes the person feel young again, that's really not adaptive for the acute trauma situation. Yeah, it's fantastic. Thank you. I've learnt something there today as well. That's great. Thanks. So is there, the next question I have for you, is there anything that's important for therapists listening today that you would really like to share about schema therapy or acute trauma?
Yeah, of course. Yeah. As I said before, I believe that a good and well-trained schema therapist can help a person who had acute trauma and maybe going through stress or severe stressors. But again, I recommend that the therapist is experienced, because we need to identify the core emotional need that's present at that moment and decide quite fast the best clinical strategy. And also because the work can lead to vicarious traumatization. So that makes it quite difficult. So at some point, we are not emotionally able to help these patients. And other times in our lives, we can. So that's important to identify our limitations, our personal situation. And also to have a support system is important. And supervision is recommended. And anyway, I think that what's very, very important is to do research about these interventions, because they have shown in my clinical experience and the experience of other therapists to be very effective. Okay, and they have been researched, and the research has shown to be effective with the PTSD, but with acute trauma, I think it's important to have research. And I encourage your audience, Nadine, if there are any researchers out there that, they show interest and they do some research about these interventions.
Thank you so much for that. So just in summary for everyone listening today, some of the key points are about how we can use schema therapy for acute trauma. There are some key interventions that we have within the model that make sense in terms of acute trauma, because acute trauma is happening to real people, and we know that real people come with modes and schemas and core unmet emotional needs. But you need to know your stuff, you need to know about acute trauma, and you need a competency as a schema therapist before you would start rolling out schema therapy as your first option. And Patricia's also pointed out that trauma-focused CBT and EMDR therapy have an approach to acute trauma that's also useful as well. And certainly the EMDR therapy model fits very closely to, I think, some of the things you've described in your approach with imagery rescripting. So, and then on top of that, I think a very key point is that everybody could probably benefit is thinking about how we label the vulnerable child mode for our clients I think at any stage of therapy, actually, and we might be wanting to think about what our client needs to be doing in the world outside of our therapy room, and ensuring that we're not creating regressive states in people that can't be contained anyway. So I personally, I found that really helpful today. And as we've also talked about, that critic modes and schemas very commonly become activated by traumatic events. It's something I've seen happen in the work that I do. And I find mostly, just for everyone's benefit, I mostly work with PTSD or historical event traumas that are linked to relational patterns and things like that. But certainly when you have a trauma, what I've seen in my clients is that it maps onto the existing schemas. It's not always that it creates a schema, but it's the framework is there, and that's why they become so distressed or develop PTSD in the first place. So it's been really great today, and I think we could probably talk for a really long time about all of this stuff.
Yeah, I would just like to say something about the difference between working with the PTSD and acute trauma, which is the emphasis on affect regulation techniques. Okay, I was very interested in the results of the IREM study, okay, where they found actually something that we were not expecting, and that's that affect regulation and emotional stabilization before doing the work. Actually, the image or scripting was not so necessary, right? And also, you know, they found that there's some generalization effect, okay? I was very interested in Dr. Christopher Lee's presentation in the ISST convention. So, but with acute trauma, I think it's very important to help the patient to learn or to refresh techniques, affect regulation techniques and strategies that can be helpful to them, because they will need it. They are likely to have ongoing severe stressors, potentially traumatic stressors. So I think that's something that we should emphasize and keep in mind.
Yeah, and I agree with you there. And the way that I see it is it's building the healthy adult mode when we teach those sort of things, or as you mentioned, refresh, because some people who experience acute trauma, they actually generally would know how to soothe themselves and settle themselves, but it kind of, because their modes shift around, I guess, because of the terror, they lose access to that. So yeah, and I think there's a lot of conjecture about that, but even if we're not doing a massive stabilization period for complex trauma, it's unlikely that no skills need to be taught. So I think sometimes when people see that research, they think you don't have to do anything. But even with the IRM studies, they would have taught them, or at least checked they had some skills in place to, particularly for those doing the EMDR, it's just part of the model that's how it would have happened. So yeah, that's a really, really great point, that we need to make sure that there's an emotional regulation toolkit for the client.
Right. And you were talking about different parts that get activated. And that's an important point, because some people feel they're going crazy. They don't understand what's happening to them. And that's emotionally intense, even for the therapist. So doing mode tracking can be very good, showing them the different parts that get activated, and that they are likely to be temporary, or those distressing events, or the distress is likely to go down. So instilling hope, I think, is very important.
Yeah,
because after all, they're likely to recover on their own.
Yeah, so that's quite a strong psychoed component about that we all have parts, and that trauma can just shift the structure of that. So a different part is driving the bus, so to speak, of the person's life, and that we can get those things to shift around again. But right now, that's why you feel small, or very stressed, or unable to take care of your children the way that you normally would. So yeah. Okay, so obviously you're a wealth of knowledge, and I'm really interested about what you have coming up that people could take advantage of to learn more from you. So is there any training offerings coming up, or what have you got available?
Well, I'm planning to help a bit, I do my best to help with the Turkish, doing some training to Turkish psychologists, psychotherapists. And if anybody is interested in doing some supervision or organizing a training, I will be more than happy to help.
Yeah.
So you can share.
So
my
I've
email.
heard wonderful things about you as a supervisor, actually. So that's a big 5-star recommendation for Patricia as a supervisor. And maybe people can just look out during the year. Sometimes you post ads in the Schema Therapy Made Simple group for your events. But that's great. And it's lovely to hear that you're helping out with Turkey. And I know that you've been very supportive of the Ukraine Schema Therapy community. And I think it's just part of your very genuinely caring nature. It seems to me you don't just care for your clients, but it's a bigger picture of humans in the world and wanting them to be well. So that's a lovely part of who you are.
So yeah, thank you, Nadine, for your invitation. It's been fun, interesting, always interesting to exchange ideas with you through WhatsApp.
Yeah.
So thank you for accepting my invitation to the Trauma SIG. That was really interesting as well.
Oh yes, thank you. So for those of you who don't know, I came along and I spoke about how I combine schema therapy and EMDR. So that's really how I'm working all the time. What I was going to say, and thank you for putting up with I was a bit slow to wake up this morning, everyone, and Patricia's of course in the evening. So it's going a bit strange on the live. So it's probably a good time for us to wind up. And I will just come off the live and spend a bit of time talking to Patricia. So bye everybody, and thank you again, Patricia.
Bye-bye.